Uh, Hi, good evening, everyone. Welcome to the another FCPI exciting podcast. And today we're going to discuss about antibiotic PKPD. And we have the great host, Dr. Jason Pogue. He's a clinical professor of infectious diseases in the Department of Clinical Pharmacy at the University of Michigan, College of Pharmacy in Michigan State. And before he joining in University of Michigan faculty, he spent over a decade at Detroit Medical Center as a ID clinical pharmacist. There he is also as a co-chair for the antimicrobial stewardship program. Dr. Pogue received bachelor degree in chemistry from the Gannon University before obtaining his Doctor of Pharmacy degree from the University of Pittsburgh. And he then completed PGY Pharmacy residency at University of Pittsburgh Medical Center, followed by ID Infectious Diseases PG2 resident at University of Michigan Health Systems. And his research interests focus on epidemiology and management of multi-drug resistant gram-negative infections and antimicrobial stewardship. And Dr. Pogue is well recognized infectious disease leader across the world, and it is evidenced by a significant contribution over 100 peer-reviewed articles and over 100 abstracts and multiple book chapters and the presentation at numerous international and national conferences. And Dr. who currently is a past president for Society of Infectious Disease Pharmacists USA and currently active member of the United States Committee on Antimicrobial Susceptibility Testing, where he is intimately involved in the antimicrobial susceptibility and breakpoint testing. It's my pleasure to invite you, Professor Jason Fogg.
Thank you
Welcome you,
so
sir.
much for having me. It's an honor and a privilege to be here, and I look forward to our discussion today.
Yeah, welcome you, sir, once again. The Professor Fogg, can you brief you about some antibiotic history of antibiotic pharmacokinetics and the dynamics? How these concepts?
Yeah, yeah, happy to do so. Again, a history lesson could take a long time because it's been a while, but it's kind of crazy to say. But believe it or not, it's been about 50 years since some of these concepts have really started to formulate. When investigators started realizing that antibiotics could be grouped into different buckets based off of how exposures kind of impacted bacterial kill, and they saw, some seemed to be concentration dependent. The more you gave, the more kill you saw. And some that kind of capped out and they were more exposure dependent, what we now call time dependency. And concepts like post-antibiotic effect, again, these are all back into the 70s. If you think of like some of the famous publications in PKPD when it comes to antibiotics, if you think of like aminoglycosides, right? And how we found that peak to MIC ratio really was associated with efficacy in patients. That publication is from 1987. So this is like 40
That's
years
great.
old at this point in time. And then if you kind of follow that history, once we learned that, and we figured out that there seemed to be some satural toxicity. If you go into the 90s, that's where you start to see, once daily or high dose extended interval aminoglycosides really starting to take advantage of these things that we were learning. And whenever I think about the history of PKPD, I always think about what the Sentinel article that I was given when I was training, which was from Bill Craig at the University of Wisconsin. Again, Bill's kind of considered the grandfather of PKPD when it comes to the ID world. But this is his famous publication in CID in 1998. It's called Of Mice and Men, where really it kind of came out into the open, I think, a little bit more of the importance of optimizing exposures to optimize patient outcomes. And so as you then move forward into the 2000s, that's where some of the beta lactam principles became more prevalent in clinical practice. So for some of us who've been practicing for a little bit longer of a time, we know that in the 2000s, it's when we started to say, well, instead of giving this dose of meropenem every 8 hours, why don't we divide it every 6 hours, right? Because it's a time-dependent antibiotic. It optimizes the time above the MIC. You kind of the next logical step with that, if you look in the late 2000s, that's when the pubs started to come out on extended infusions. You think of Tom Lodice's kind of sentinel publication with piperacillin tazobactam, showing that again, if you give it as an extended infusion, you optimize that time above the MIC, you really can improve outcomes. And it's kind of crazy to think about, but if you think about where we are now today, this is so ingrained. Like antibiotic PKPD is so ingrained that if you're going to bring a new drug to the market, It is ingrained into the drug development process. Again, before they even think about giving a drug to a patient today, they do all of the preclinical PK/PD, right? They identify what's the target. They look at dosing strategies to cover MICs that they see. They make sure that it's safe, and that's what's carried forward into phase 1 through 3 studies. And so if you look at some of the newer drugs that have come out, again, plazomicin isn't a drug that gets a lot of play, but if you actually look at it, right, it's a once daily dosing of that drug. If we look at gent and tobramycin, if you look at their package inserts, they're every 8 hours because we didn't know these things. So today, it's actually embedded in the process. Think of some of the new drugs that have come out, like cefiderocol, right? The standard infusion is 3 hours, right? It's not like something us pharmacists are trying to convince people to do. It's literally in the package insert. And so it's kind of crazy as you kind of take this history lesson over the last 50 years just to see how far we have come.
Okay, Professor. It's like that's a great summary. So with a move on to the next question, with this much of strong research of antibiotic PKPD history, then how do these PKPD concepts like helping the antibiotic approval from the regulatory point of view in a
Yeah,
preclinical
so that's a
clinical
perfect
study?
kind of follow-up to what we just talked about. And we kind of alluded to it in the first question, but PKPD analyses assessment are now standard for drug development. So if you kind of walk through their process, the first thing that they're going to do is they're going to figure out what the PKPD parameter associated with effect of a novel antibiotic is. And then essentially what they will do is they'll say, okay, this antibiotic is optimized by AUC to MIC or time above the MIC, and here's our targets. Then they look in vitro, right? And they say, here's the MIC distributions. And so to achieve that exposure at this MIC distributions, this is how we would want to give this drug. And so then the next step is, can we do that safely in an animal, right? Like, can I do that or am I going to kill everybody if I give that much of this compound? So before it even gets to the patient level, they're assessing all of this to kind of give that proof of concept. And so then what they do is then they've learned that in the preclinical model, it says, you know what, we can move forward with this. And then if you look at the phase 1 studies that will follow, they'll make sure you can safely give those doses to patients. And if you can hit your PK/PD targets. That ultimately ends up being the doses that move forward in the phase 2 and phase 3 studies. And that's why you'll see that when drugs come into the market today in their clinical trials, they often do very well, right? Because they put all of this into it beforehand. And it's not just like, let's hope this works in patients, which it kind of used to be like. Now they kind of go in and they've kind of stacked the deck in their favor because they've done all of this analysis beforehand. So I would say, to your question, PKPD is integral now to modern day drug development. And again, you can see it as we talked about in some of the dosing regimens and approvals recently.
Okay. So you said like there's a great role of PKPD in the drug approval, like you mentioned, like preclinical. So when we study the most of the antibiotic PKPD papers, and so every time they mention like time kill studies and something like neutropenic mouse anti-infection model, like how these studies and performed, and what is the importance of these studies and how you can interpret in the when you're reading the paper. Can you elaborate on these studies, please?
Absolutely. So you kind of talked about two buckets here. You talk about time kill studies and you talk about neutropenic animal models, whether that be thighs or that be lung. And I think they have different roles. Particularly the neutropenic animal models, I think are really critical to the story. But time kill studies are pretty straightforward. So this is essentially an in vitro test where an inocula of an organism is exposed to a concentration of an antibiotic over time. And so it can give you this kind of, and so what you do is you periodically take samples and you see, are you getting reductions in organism? Are you getting stasis? Are you getting kill at these different time windows? And so this can kind of, I kind of think of time kill studies as a proof of concept. And so it
Okay.
allows you to get an idea if the concentration is going to be static, it's cytal. I think a big place that we see this, you and I were talking before we kind of started
Yeah,
the
yeah.
pod today about combinations of aztreonam and avibactam. And I think it can kind of give you that idea of, is there synergy present? Is there this proof of concept that whatever I want to do kind of moves forward and would be effective? I think there's limitations to time kills because as we kind of alluded to, right, it's just one concentration over time. That's not how we give antibiotics, right? Sometimes we give continuous
Yes, yes.
infusions, but we don't give a same concentration of 10. So it doesn't necessarily reflect how we would give the patient the drug. But I think it's an important first step because it's a little bit easier of a model to do to be able to say, you know what? The concept looks to be working here. Either this exposure looks like it should help, or maybe these two drugs given together would be beneficial. And it kind of gives you that first step in the process. I think that the neutropenic animal models, on the other hand, are really critical because they're informative of an in vivo effect, right? So you're not talking about a test tube now, you're not talking about some sort of in vitro pharmacokinetic model. You are talking about giving an animal a drug, right? So you can kind of get an idea of how it would work in as an actual in vivo experiment. And so the way that those kind of set up is that the first step, and I think that again, it's important for our audience to understand because they read this, right? They see neutropenic thing. It's like, why are you making these poor mice neutropenic, right? And the reason simple is that these organisms aren't quite as pathogenic in the animal. And so you have to render it neutropenic so that in the absence of antibiotic, you're going to see that organism grow and ultimately cause disease and probably death in that mouse. And so you kind of get that as the baseline. And after you do that, you can then test the growth of the organism over 24 hours without antibiotics and see what happens. Or you can use it in with antibiotic exposures. And you can do this for a lot of different reasons. The first thing that you can do is you can actually figure out what the PK/PD parameter of interest is. So you can do dose fractionization studies, and I think we'll talk a little bit more about that later, but you can identify what the PK/PD target is. You can also do things like simulate human doses of the drug and figure out, do you see effect of the drug, right? Is it working at these various MIC levels? And then you can also assess the survival rate with and without antibiotics or with different antibiotics. So again, it's giving you this in vivo experience of simulated exposures of the drug to kind of give you a better idea of if I actually gave this to a patient, would I expect these different kind of effects? And then just for our audience to make sure we're kind of all on the same page, there's two different models. There's the thigh model. And again, generally what we think about with the thigh model is this is reflective of a easily accessible infection. So maybe a bloodstream infection, maybe a skin infection, those types of things. And then there's a lung model, because as we know, penetration into the lung, exposure to the lung can be different, and it can kind of give you that idea of efficacy for treating a pneumonia. And so that's kind of how we use those things. But I would say that neutropenic animal models are really critical to understanding PK/PD of a drug.
Okay. So thank you for the excellent summary. So basically, time kill studies, basically in vitro studies, they can help you to determine the concentration. And that neutropenic thigh infection, lung infection models are the in vivo studies. They can help you to extrapolate the PK/PD and dose fractional studies.
Yep, you can get a lot more information out of the neutropenic models. Yes, for sure.
Okay. So coming to the next question, like by using these models, we are able to identify which antibiotic is the time dependent, which antibiotic is the concentration dependent. Can you give examples of time dependent antibiotic and the concentration dependent antibiotic, and how is this concept is emerged actually, and which are the antibiotics falls in this different category?
Yeah, I think that's a very fluid conversation. I think it's dynamic and changing over time. But when you kind of bucket it off, I think from a time-dependent standpoint, the big answer to that question is your beta-lactams, right? These are optimized by the time you are above the MIC, so the amount of dosing interval that you're above the MIC. And so we take advantage of that when we're dosing our antibiotics by either giving more frequent dosing. So instead of giving the dose divided Q12, we give it Q8 or Q6 because that allows you to optimize the time above the MIC, or that's where the prolonged, extended, continuous infusions come into play. So the beta-lactams are kind of our hallmark. And honestly, not a lot of other antibiotics are principally dominated by time dependency. Probably one that's closest are the oxylidinones, so drugs like linezolid, and that's why we monitor troughs in those patients, right? It's a kind of similar concept. Um, with regard to concentration dependency, and so concentration dependency, kind of the most common thing that would be true concentration dependent would be Cmax to MIC ratio. And there are some antibiotics that have a peak to MIC ratio effect associated with them. Examples would be the aminoglycosides, would be the fluoroquinolones. Dapto has some of these kind of associations. But what I would say is that it's not just that, it's kind of actually this hybrid of the two. And so there's your time, your concentration, and then there's kind of your middle ground, which is your AUC to MIC drugs. And all that is, again, from a pharmacist standpoint, from a chemistry standpoint, from a math standpoint, AUC is total drug exposure. And so it's kind of a hybrid of concentration and time dependency.
Right.
And honestly, that's where most drugs fall.
Okay.
Even the beta lactams to some degree fall in the AUC to MIC bucket. How good that is dependent a lot on the post-antibiotic effect that you can see with drugs. But again, drugs like vancomycin, aminoglycosides, quinolones, daptomycins, even the oxylitinones, again,
And the
polymyxins, what you'll
mixins.
find is that
Yeah.
most drugs fall in
Mixins.
this middle bucket, where the way that we optimize those drugs is just optimizing the total daily dose. So how we divide that out isn't as important. Remember, for time dependent, we want to give it more frequently. For pure peak to MIC, we want to give big doses once a day or whatever that ends up being. AUC to MIC doesn't matter as much for efficacy. Now, where it can matter is for safety, right? So daptomycin is a great example. AUC to MIC, you could divide a daily dose however you want. However, if you divide it out and give it Q12 or Q8, you actually
Awesome.
see CK
Okay.
elevations, right?
Yeah.
And so it can matter from a safety standpoint, but from a pure efficacy, it's not a big player there.
Okay. So that's very nice. So you mentioned about MIC in like your previous conversation. So when we see in the culture reports, we often very see like antibiotic MICs for each organisms. Like how these MICs decide and what is the like pros and cons of these MICs when you're deciding the PKPD breakpoints.
Yeah, so again, MIC is imperfect, right? It's what we can get. And I think it's important to note that there may be better things that would better predict efficacy, but they're not things that we can readily get for our patients, right? You can get an MIC value. So whether they're great, which many of us don't think they are, they're the thing that we need. And we need some sort of reference point to be able to say, here's the number. I can either kind of accept, I can expect something good to happen if I give a drug or something bad to happen if I give a drug. And so I think that even though MICs are very imperfect, they are what we can easily get. So I think we should kind of keep that in mind when we have these conversations. But there are certainly cons to MICs as well, right? And I think the biggest downfall is that I would think of two main things. One, many institutions can't get them, right? You can't get an MIC test, and so you need a disc zone correlate to that, and that's an imperfect. So you take an imperfect test to begin with, and now you have an imperfect extrapolation to what that means in a disc zone. So that can be problematic. And so when all of our decisions, and again, I'm an ID pharmacist, right? We're ID guy. We love this stuff, and we love to optimize PK/PD, but you're having you have a lot of people who don't have that level of information, and so they have to work with what they can get. And that might just be a disc that has a big fat S, an R next to it, and that is what it is. So that's one big issue. And then the second is that remember, MIC tests are extremely imperfect. They're not reproducible in a lot of ways, and depending on your testing methodology, you might get a different answer. If you took the same organism, right, and you tested it on your automated susceptibility panel, you did broth microdilution, you get e-test, you might get three different answers to that question, right? And what we generally say with MICs is that in the best case scenario, it's plus or minus one double dilution. And so what that
Yeah.
means is if you get an MIC of 4, it's staring you in the face, you need to think of that as it's anywhere from 2 to 8. And so again, don't treat MICs as like biblical or like the be all end all answer. Know that it's just kind of a point estimate of where that is. And you want to consider that there's a little bit of variability in there when you're making that recommendation and when you're considering whether or not you can do. And you talked a little bit about how that applies to breakpoints. And that can be really problematic for breakpoint setting, particularly if the PK/PD exposure breakpoint happens to fall right smack in the middle of the MIC distribution of the bug drug combination. So let's say, for example, you have fill in the blank antibiotic. It doesn't matter what it is. But let's say that your PK/PD says you can target MICs with this dose up to an MIC of 4, right? Now let's also say that almost all of the MICs for that bug drug combination are in the 2 to 8 range. And so if
Yeah.
you take that variability into play, things that could be testing susceptible could very well be resistant, and
Yeah.
vice versa in that scenario. And so that's why breakpoint setting organizations have to weigh those MIC distributions as part of their decision-making process as well, because you want a reliable test. And I think it's upon us as clinicians, those of us taking care of patients, just to be aware of that. Know that, this 4 might be a 2, it might be an 8. And if it was a 2 or an 8, that might change our interpretation. And if I have a better option, maybe I want to give that to my patient in this situation. Or if I don't have a better option, I might still use this drug, but maybe I'm going to give a second drug with it, right? Because I'm not as confident in this drug that I have to give to my patient.
Okay, so that was excellent summary. Just we finished about antibiotic history and how the anti PKPD helps in the drug regulatory approvals and what are the time dependent, concentration dependent antibiotics and MIC and the PKPD breakpoints. Now we moving to the like patient scenarios like so lots of time like most of the time you are the most of the time you are talking sometimes you mention about the loading dose concepts like and what is the concept of loading dose and actually when these we can consider loading doses in a patients and and what is the concept of maintaining dose? Can you elaborate from the PKPD
Absolutely.
perspective?
Absolutely. And again, least loading dose isn't something that's unique to us in the ID world, right? This is certainly just a pharmacologic thing that we need to think about. And really like the crux of it is that a loading dose is for any scenario where you need to get therapeutic, and we'll talk about what that means quickly. And that's what you'll be taught, right? You fill the tank in this situation, we like to say in pharmacy school, right, for our students. And the question is like, what does that mean? And so I want to talk about a couple of different scenarios as it relates to this. So I think the first and foremost one is the easiest situation, the most straightforward, and that's a drug that has a long half-life. I think this is the key one where we need to be thinking about a loading dose. And so let's take a drug, let's make it ID centric, right? Let's take tigecycline, for example. Again, drug we certainly need to give to patients with drug-resistant infections. Well, the half-life of that drug is 2 days, right? And so what that means, if you think back, if you get that hamster wheel going again in your head, and you think back and we say it's 4 to 5 half-lives before we reach steady state, and steady state is our therapeutic concentration. If you do that math right, you're talking a week before you're
Yeah,
therapeutic with the drug. That doesn't sound great, right? And so what we do is we give a one-time bigger dose to fill that tank first. We take away that week that it takes to get to the therapeutic concentration. So if we dose tigecycline, what's the dose? It's 100 times 1 or 50 twice daily, or if we're using high dose, which is something we do much more commonly today in our drug-resistant infections, it's 200 milligrams times 1, fill that tank up, and then 100 twice a day, right? And so that's kind of the straightforward one. There are other ones where we have this conversation. I think it's worth talking about for our audience as well. The one that I often get asked about is what about when you're giving a patient prolonged infusion of a beta-lactam, right? So you're giving the drug, let's say that you're giving piperacillin tazobactam as a 3-hour infusion, right? And the question is if my first dose, right? If I'm giving the first dose and I'm giving it as an extended infusion, is it taking too long to get therapeutic in that scenario? So should I give a loading dose, meaning a bolus dose times 1, to get above that MIC and then start the prolonged infusion? I will tell you that theoretically that makes sense. I don't care about this one that much. I don't think it's a huge delay in this situation. Nothing's ever showed me that compellingly. But if you're concerned, I think it's very reasonable to do that. And some people call that a loading dose, even though technically it's not. And then the third example is every pharmacist's least favorite drug, which is vancomycin, right? Everyone's got a dose vancomycin. And the question is, so again, think about what we talked about. Vancomycin has a 4 to 6 hour half-life, right? And so if we do our math, we say that's a day before your therapeutic. And so if you have a patient who's sick with an invasive MRSA infection, do you need to load the tank, right? Do you need to give a loading dose times one? And I have no issues with this concept. I'm actually supportive if you want to give a loading dose, but remember that PKPD is a little bit more complicated than that. And what I mean is that vancomycin is an AUC to MIC drug. That's how you optimize exposures of that drug. So the loading dose is one thing, but what actually drives a daily AUC is going to be your maintenance dose, right? And so for me, the most important thing you can do, whether you choose to do a loading dose or not of vancomycin, is that the most important thing that you can do is you can start your maintenance dose at the right time. Because what I see in practice, right, is a lot of people will give loading doses and then they wait 12 hours before they give the maintenance dose, and you've completely defeated the purpose because the drug's gone at that point in time. And so the key thing I would just encourage us to think about if we're going to do a loading dose for a drug like Vanco is making sure our maintenance dose starts at the right time, because that's what's going to drive our total daily exposure, our AUC, which is the predictor of efficacy with that drug.
Okay. Thank you, sir. Like totally worthy discussion. What you mentioned about when to use the maintenance dose after loading dose. In our institution, we made a protocol for each an antibiotic that depends on the PKPD. Once you start the loading dose, when to repeat the second dose, like generally we
Awesome.
call the maintenance dose. Suppose if you have a patient with a sepsis and septic shock, suppose if you give beta-lactam antibiotic, suppose meropenem 2 gram, if you are planning
Yep.
for the meropenem as a continuous infusion, after finishing up the loading dose infusion of the meropenem, you have to immediately start continuous infusion of the meropenem. Suppose if you're planning for prolonged infusion of meropenem, then we can start second dose of maintenance dose after 3 to 4 hours of the
I love
meropenem
it.
loading dose. Yeah, so these are very important concepts.
Yeah,
And
and I feel I'm very happy to hear you say that. It looks like you take great care of your patients, and I'm happy to hear it.
yeah,
But that's a concept that's often missed. Is that
yeah.
you've defeated the purpose if you
Yes,
don't do that
give the
next.
yeah. So the correct time also very important.
Yep.
And the cuff thing, like very important point is especially beta lactam loading dose. Generally, they have a less volume of distribution and the shorter half life. So generally, we prefer to like when before the clinical pharmacist in Hinduja. So generally, even loading dose also they try to administer like 1 to 2 hours. So there is no point of giving loading dose 1 to 2 hours. Then we came into the picture and we changed our protocol to like 15 to 30 minutes, the loading dose.
Love it.
Then
Cool.
like yeah, so like these are very important things. And the
I
polymyxin,
agree.
the loading dose, they recommend like 2 hours infusion. So to prevent the toxicity. Yeah.
Love it.
Thank you, sir. Explain summary. Then sometimes like when we are dosing the antibiotics in the most of the literature, they mention about PTA values like probability of target attainment and cumulative fraction of response. Like these are very new to the clinicians, and it's difficult to understand. Like how does it matter when you choosing the antibiotic doses in a patient management? Like how is these two values going to help in the choosing the right antibiotic? Can you elaborate on this?
Yeah, great question. And I'm glad you asked it, particularly as people read papers and they see these words. It's like, is this good? Is this bad? So
Yeah,
I
they
love
get
it. So PTA stands for probability of target attainment. And so that's exactly what it sounds like. And so basically what that means, if you give a given dose of a drug, again, whatever dose is being assessed, and there is a given MIC value, if you give that, it's the probability that you're going to hit your PK/PD target at that MIC value. And so there's a very fun math nerdy way that they do these types of things. You'll read about these publications. And I think it's worth talking about a little bit, but kind of the way this kind of process works overall is the first thing is, right, you have your MIC distribution, right? So you know what that is. You have your PK/PD target. So let's just say we're talking about a cephalosporin and our PK/PD target is a time above the MIC of 60%. And so the question becomes is if I give piperacillin and tazobactam, 4.5 Q6 is a 3-hour infusion. How likely am I to achieve that at various MIC values? And so what happens is that we need to look at PK in patients. And the thing that we have, right, is we have these very small pharmacokinetic studies. Sometimes they're phase 1 data, sometimes they are critically ill patient data, but we have these very small 10, 15 patient PK studies. And so then what is done, this is where the fancy math comes into play, is if you think about that, if you read a PK paper, right, you'd have your median value for things like clearance, volume, half-life, and then you'd have these ranges. And so what happens is something called a Monte Carlo simulation is performed where they basically take that. So you have 15 patients and they simulate patients that will have various PK parameters along those ranges. And so essentially your 15 patients then become 10,000 patients. And so
Yes.
then what you do is what you end up with is 10,000 concentration time curves for a given dose. And so what you'll do then is you'll say, okay, of those 10,000 patients, when the MIC is 0.25, all 10,000 achieve their time above the MIC of 60%. So the probability of target attainment is 100%. And then you go to an MIC of 0.5 and you do the same thing. And one, you do, and so on and so forth. And the general rule of thumb is that we want a PTA of 90% or higher. And in that scenario, we consider it targetable with that dose. Now, there's a couple of caveats that come to that that I'd be remiss if I didn't comment on it. First off, while the 90% number is generally accepted, and it's actually something we look at with susceptibility breakpoints as well, note that there's nothing magical about 90%. That was something that was decided, that's good. But does that mean that if it's 82% and you don't have another option, you shouldn't use the drug? Absolutely not, right? 82% is still 82%. That means 4 out of 5 times you'd expect to achieve that target. So one thing I want you to know is that if you're reading these analyses and you're trying to apply it to a patient, and at the MIC your patient has, it looks like 80%, that doesn't mean you can't use the drug. It means you have to weigh that in light of whatever your alternative options are to give that patient. And then the second thing I think it's really critical that our audience appreciates is that a Monte Carlo simulation, even though you've now made 10,000 simulated patients, that's going to be reflective of the source population. So if it's a phase 1 study in healthy volunteers, you are simulating 10,000 healthy patients. And as we know as pharmacists, right, PK in healthy patients and PK in
That
critically
differ.
ill patients can look very, very, very different. And so
Exactly.
ideally, you're getting PK sourced from the right population. And I think piperacillin and tazobactam is a really good example of this because some of those initial publications that suggested you could give lower doses, that was simulated with healthy volunteer PK. And once you did the same thing in critically ill PK, you needed to give higher doses, extended infusions to be able to achieve your targets at MICs. And so I think that's really important for our audience to think about when they're trying to interpret PTAs. And then
Yeah, I
the
think.
other thing, I'll give you a second. You
Yeah,
want to
you
say
can
something?
continue. No, I think post Marino you talked about you have a one paper on tazobactam combinations. There you talked about PT and CFR about the tazobactam combination. That's
Yeah.
excellent paper. So you can continue.
Thank you. I appreciate that. And again, we get into a lot of those concepts. The other term that you brought up was CFR. And again, CFR to me is a little less critical, but I do think it's important to understand what it is. So CFR stands for cumulative fraction of response. And honestly, this is basically just a different way of assessing the same thing. So let's say that once again, let's use the pip-tazo example, and we're trying to get the cumulative fraction of response of pip-tazo 4.5 Q6 hours is a 3-hour infusion against all Pseudomonas at your institution. So basically what you're trying to see in a CFR is of all of these given organisms that I'm interested in, how likely are we to hit our PK/PD targets? And so essentially what you do is each MIC value is going to have a PTA, like we just talked about, a probability of target attainment, and then you weight that by the frequency of having pathogens at given MICs. And so again, you have your MIC distribution, you have your dose, You know the probability of target attainment of all these MICs, and you can say that we would expect that at my institution, based off of this dose, the MIC distribution that we see, we have a cumulative fraction of response of 75%. And that means we would expect to achieve our PK/PD targets in 75% of our pseudomonads. And then we would think about that. Does that make it the best option for us empirically? Well, it depends on what other drugs look like as well. But when you see CFR, it's kind of the same thing, but it's just applying it rather than just to a specific MIC value, it's a distribution of MICs for a given pathogen or group of pathogens.
Okay, thank you. So then uh, next we have like sepsis patient. We describe the loading dose and we give some antibiotic. Then we discuss about the PTA values. And we have some special populations also, especially in ICU setting. And we see lots of sepsis with obesity and sepsis with pregnancy. I mean, most of the septic shock patient we have geriatrics, and the most of them they underwent different renal modalities like SLED and CRRT. So how can we like apply these PKPD principles dosing of these particular populations?
Yeah,
Some
great question.
concept.
And a lot of times it's fingers crossed, right? Because you're trying to do your best. And what this comes out, so you're talking about beta lactams largely in this situation, right? And at least what we've been talking about today. And so you're talking about a hydrophilic drug, right? And I think that that becomes important because really what this whole question comes down to, right, is how can I best estimate clearance of the drug? Because clearance is really going to be the driver of how I need to give the drug. Yes, you'll see volume distribution changes, but for a time-dependent antibiotic, the bigger impact on exposures relative to the MIC is going to end up being the clearance piece of the story. And so I think you brought up a lot of important things that we should comment on. The first is you said a septic shock patient, right? So this is a patient where we need to get the exposure right, right? This is a critical, no pun intended, but this is a really important population that we need to get it right. And so if we're going to mess up in this patient, we want to overdo it, right? That might be different than an 83-year-old with a maybe urinary tract infection that has a borderline creatinine clearance. And I'm afraid of giving too much cefepime and having neurotoxicity or whatever. Right? It's a different scenario. This is a critically ill patient that, you know what, if I overdose them, so be it. I want to save their life, right? That's the thing that I need to do at this point in time. And so what we'll do, and I'll be interested to hear what you do, but what we often recommend, because these patients might be in acute kidney injury as part of their septic shock, right, is we give them full dose for a few days either way. And we let that settle itself, right? We let the dust settle, we see what happens, and then we kind of reassess after that time point. I'm curious, do you have similar processes there?
We have similar thing. Now we try to give the full dose at least 24 to 48 hours. Then we take a call on further how the patient is doing. Is that
I love
clinically?
it. That's awesome.
Yeah,
Yeah. So, and I think that that's kind of emerged. Our critical care friends, and I
yeah,
think have really helped us over time with that. And I think that we feel pretty good about that. The
yeah.
other option you talk about is just kind of like general dosing of these patients, right? And again, regardless of it's complicated, right? Because again, there's a lot of different equations. It's creatinine, it's cystatin, it's all these things. Like there's a lot of question marks there. And what I would actually kind of highlight more than anything is what we already talked about. It's thinking about where you want to be wrong. And so depending on the patient, like you might handle things a little bit differently. So again, critically ill patient with a rip roaring pseudomonal pneumonia that has an elevated MIC to the drug that you're
4 to
treating,
8 times of MICs generally we
you're,
do.
you're gonna you're gonna be a little bit more aggressive, right? You're gonna do your best to estimate clearance, whether it be by the flow rate of the sled or the CRRT, or whether it be I'm trying to do this fudge math because they're elderly and I don't buy the creatinine, right? You're gonna do your best in that scenario. But for me, I think what I would say more than anything is err where you need to err. And again, if you need to be aggressive, regardless of what the clearance shows. Like, don't be stuck on the creatinine clearance is 48 and the 30 to 50 dose is this, so I'm going to do this. You need to take into consideration, do I need to be a little bit more aggressive and turn it up? Or do I need to turn it down a little bit because I'm worried more about safety because I don't even know this patient has an infection, right? So like you need to consider those concepts.
Okay. And technically, when you're treating the septic shock patient, there is no standard equations to calculate the creatinine clearance.
True.
Like CKD, EPI, or every equation come with their pros and cons. So generally, we see the what you told. We see if you want to treat aggressively, we can go with the higher dosing. Sometimes when we want to adjust the dose, we can see the urine output and blood urea, and those things we'll consider. Yeah,
I love that answer. And again, I think it gets back to what we just talked about, right? Like be a clinician, right? Take care of your patients. Don't treat the lab value, understand what's going on in your patient. That's a piece of the story, but you have
yes,
to use some kind of clinical judgment in making those calls, regardless of what it calculates out to, because they're all just estimates, right? Regardless of which one you want to use, they're estimates because we don't know the actual function.
creatinine clearance. Yeah, and so. We have like beta lactams, and the most of the recent literature says that we have to give prolonged infusions or continuous infusion when you're treating the gram-negative infections in sepsis and septic shock patients or any deep-seated infections like pneumonia, meningitis. So whatever it is, like there the like so many RTCs came recently, Mercy trial and the Blink trial, Blink 3, and so they the result shows that they didn't much benefit in mortality. And what is your comment on this? Like when for a clinician, like they always see the mortality, whether the particular intervention is improved the patient mortality or not. But unfortunately, this prolonged infusion or continuous infusion practices doesn't really not turn to be a improved patient mortality. So because of we have a like wrong clinical trial or because of we can't see the prolonged infusion in that way.
Yeah, I think it's a great question. And I think that, again, Mercy came out first, right? Mercy had a lot of issues with it. Particularly, there was a lot of resistance in the study. And then it's a relatively small sample size. And then Bling comes out, right? And again, you can interpret Bling however you want to interpret
Yeah,
Bling, right? It's
exactly.
perfectly equivocal that no matter what you want the answer to be, it supports that. What I would kind of tell
Yeah,
our listeners, is that, think about what those studies are. Because what they are is they're empiric therapy for sepsis, right? So that's suspected or documented infection. And so that's going to include a lot of patients that, one, aren't infected. Those that are infected, a lot of them are going to have gram-positive organisms. They might have yeast, they might have other things. And even those with gram-negative infections, right? The majority of those are probably going to be low MIC organisms. And so your effect size where you might actually see a benefit is going to be a very small subset of the study. And so honestly, the top line of the study is kind of consistent with what you'd expect to see. If you believe those to be statistically significant and all that, again, that's a different conversation for a different day. But again, a 10% relative reduction is about what you'd expect for all of those reasons. Now, again, I don't know that I believe what I see in that study either, because if you actually get into the supplement, there's some interesting things that, in gram-negative infections, there wasn't a huge benefit seen. But again, regardless, what I would say is that you wouldn't expect to see some gigantic benefit in one of these trials because of what we just talked about. And so for me, and again, I think you can debate either side of whether or not these studies show a benefit or don't show a benefit. And I think those are fun discussions. But for me, either way, they don't take away from the concept of why we're doing prolonged, extended, continuous infusions. They don't
yeah,
refute that
exactly.
practice. And honestly, even if you say at best there's a mortality benefit, at worst there's no benefit or no worse outcomes, that's still worthwhile to do it. Because if anything, there's a benefit, right? Think about when we give steroids to patients with meningitis. You have data that shows a benefit, you have data that shows nothing, but there's nothing that shows harm. And so it's a relatively easy intervention that
Yeah, simple
probably
intervention.
improves
Yeah.
outcomes, and we should do it, right?
Okay. So thank you for that excellent comment. And so coming to the your work on US cost United States of Antimicrobial Susceptibility Committee, and so I read one of your recent papers on PIPTA's breakpoint for enterobacteriaceae. I think CLS and FDA recommending breakpoints, but US cost is not recommending. In the same way, either same way for the polymyxin for Acinetobacter and Pseudomonas infections. So generally, piperacillin tazobactam one of the main empirical therapy in ICU patients in Indian settings, and the polymyxins one of the mainstay treatment for the MDR GNB infections.
Now,
So yeah, can you make a comments on like why UCAS recommended the not recommended the
yeah,
breakpoint?
I'm certainly happy to comment on this. And again, I think more than anything, what I would say to our audience is if you're interested, read why we say we did what we did. And I would also encourage you to read what CLSI said they did and why FDA did what they did. Again, I obviously am going to say what we did is best, right? Because it's me, right? Obviously, that's my selfish belief. But I think all groups make good points, and the clinician needs to kind of understand them. But I will tell you why we did what we did. And so with us, where we did not recommend pip/tazo breakpoints for Enterobacterales were either third generation cephalosporin resistant Enterobacterales, which we kind of use as our poor man's way of saying ESBL producers, right? Or for the AMP-C organisms, Enterobacter, Citrobacter, Klebsiella orogenes. And so those are the two places we didn't recommend breakpoints. And the reason's simple. For ESBLs, yes, piperacillin PK/PD is important, but what's equally, and you could argue more important because of what you need in that, is the beta-lactamase inhibitor exposure, the tazobactam
Yeah.
PK/PD. And very little work has been done on optimal tazobactam exposures. And what has been done is scary, right? It suggests that you're probably not getting anywhere near the amount of tazobactam you need to restore the activity of piperacillin. And then you combine that with the results from the Marino trial, and those are just red flags, right? And so we just say the evidence doesn't support using this drug here. So we can't set breakpoints because the evidence doesn't support using it. Similarly, although a little bit different, when you talk about organisms like Enterobacter, the concern is you give piperacillin the same concern you have for ceftriaxone, right? You can select for D-repressed mutants and have clinical failure, and the clinical evidence kind of supports that that's an issue with pip/tazo. And so again, we're just saying the evidence doesn't support using these drugs here. There's no way we can set a breakpoint. And so that's why we did what we did. We set it where we could set it, but we just kind of lay out there why we did that. And then if you look at the polymyxins, and again, polymyxins are very near and dear to my heart. I've done tons of research on the polymyxins in my life. And so they are near and dear to my heart. And if you look at the way that we set the breakpoints, where we said there were no breakpoints were for the treatment of respiratory tract infections. And I understand that that's not something people want to hear because I have to treat patients who have these. And again, you should consider that in the light of it. But remember, our job is to set susceptibility breakpoints, which tells us if the MIC is here or lower, go for it. If it's up here, less of a good option, right? And there's just not evidence to support that with the polymyxins. If you look at the preclinical lung models, the polymyxins don't really work in the lung, right? If you look at we talked about neutropenic lung models, they work in the thigh model, they don't work in the lung model. And we know that with drugs like colistin and polymyxin B, there's a pulmonary surfactant effect. Again, think about people tell you about daptomycin, don't use it for pneumonia because
Right.
polymyxins do that as well. And so you add that plus limited penetration in the ELF, it's not a good combination. And again, it's not just the preclinical. Look at the RCT data, right? We have two RCTs where the failure rates in pneumonia are extremely high. And so what we say is that we could make up a number, right? But it's not just the PK. Like I couldn't tell you what MIC value I'd expect a better outcome or a worse outcome with the evidence that's available currently. And so we say that the evidence doesn't support using it. Does that mean you absolutely can't use them for the treatment of respiratory tract? Of course not, right? Because you might have a scenario where you have to use them as part of a
Yeah, yes, we
combination.
have a scenarios.
And you should, but what we're saying is that the MIC value, and don't even get me started that no one can actually test an MIC value. That's a whole nother problem with the drug class. But what we're saying is there's nothing to suggest a 0.5 is going to behave differently from a 1, from a 2, from a 4, from an 8, from an anything. And so we can't set a susceptibility breakpoint. And that's what our job is, right? Whether or not others want to use it, whether or not guidelines recommend polymyxins, it's kind of a different conversation. All we're trying to do is set breakpoints. And for respiratory tract infections, PK/PD and clinical data don't support doing that.
Okay. Okay, sir. Thank you for your enlightenment on breakpoints of piptas and polymyxins. And I think we finished all the most of the questions that we covered in this session. And thank you for your time and thank you for accepting our invitation and despite our busy schedule. And we hope our audience learned lots of from this conversation. And thank you once again from the FCPI, sir.
Yeah, and I just want to also thank you. I've enjoyed our conversation today. It's great to hear the things that you're doing. They sound really smart to me, and I always like to hear people doing good things when it comes to antibiotic selection and dosing. So this has been great, and I look forward to continuing to work with you moving forward.